Dear colleagues, dear friends, I'm Marioara Simon, interventional pulmonologist from Romania, Cluj-Napoca, and it's my honor to be chair of this session. Welcome to the WABIP webinar about the role of therapeutic bronchoscopy and the use of high-frequency instruments for disobstruction of the airways. As you know, interventional bronchoscopy is art and science, and the disobstruction of the airway is the great challenge for bronchologists. Our speaker today is Dr. Majid Shafiq. He is medical director of interventional pulmonology at Brigham and Women's Hospital from Boston and the teaching faculty at Harvard Medical School. His areas of clinical and academic expertise include minimally invasive diagnosis and staging and management of lung cancer and its complications such as malignant pleural effusion and central airway obstruction. Therefore, Dr. Majid Shafiq is going to present safe use of high-frequency instruments in therapeutic bronchoscopy, state of the art. Dr. Shafiq, you have the floor, please.
Thank you so much, Dr. Simon. Thank you to WABIP for having me here. It's a pleasure to meet with all of you, and let's get started. Thank you for the kind introduction. So, when we were putting together this webinar, we sort of thought about how to frame this. What were the basic tenets of, high frequency instruments to sort of talk about and cover, and here are those four. And I've tried my best to sort of divide the talk into four discrete subsections, although of course there's going to be a little bit of an overlap. These themes are really going to be recurrent throughout the talk. So let's get started. First, the indication. Now, we're going to be talking about ways to perform tumor ablation for most of this talk, but let's back up a little bit and think about, what does your patient really need, if anything at all? Assume we have a patient with airway obstruction. Typically what we're dealing with is central airway obstruction. Central airways being the trachea, the main stem bronchi, and then on the right side, the bronchus intermedius as well. And if your patient has obstruction, you wonder whether the patient really needs tumor debulking, or do they need a stent? Do they need both? And very importantly, we must ask ourselves, do they need anything at all? So how do we figure it out? Many of you may have seen this kind of a schematic. Always helpful to think through, where exactly lies the source of the obstruction. Is there tumor or something else intraluminally? If that's the case, then of course we need to clean up the pipe. We need to perform tumor debulking. Or is there tumor or perhaps a vascular sling or anything that is extrinsic to the airway lumen? In other words, there's nothing to clean up inside the pipe. The poor pipe is just getting compressed from the outside. If that's the case, you need to think about an airway stent. And a lot of the times in malignant airway obstruction in particular, you may have a combination of both. And then you may wonder whether you need to do both. So perhaps you do tumor debulking first, and then you go on to perform stenting. But that's not the only thing, figuring out the source of the obstruction. Just because we've identified the source of the obstruction does not mean the patient has to be condemned to an intervention. You have to ask yourself, what's the severity of that airway obstruction? Is it even worth trying to fix? So how do we figure that out? Well, we look at various things. We look at the clinical impact of the airway obstruction. Does the patient have any difficulty breathing? Are they actually in respiratory failure, intubated on the mechanical ventilator, and relieving that obstruction could potentially help them get off of the ventilator and extubate, live a life? Do they have a case where, even though the site of obstruction is relatively distal and not necessarily causing respiratory distress, it is nonetheless leading to retained distal secretions and leading to recurrent or just even a single case of post-obstructive pneumonia? How bad is the narrowing on radiographic imaging? And if you And performing a bronchoscopy, how bad does it look on your endoscopic examination? Take a look at all of those things before we determine what to do and whether to do anything at all. So here's one example, of a patient. I'm not giving you the clinical vignette here, nor the radiographic picture, but just showing you an endoscopic. This isn't the complete picture, right? That's the endoscopic picture. And you can look over here to see that we're looking at the main carina, and you can see that there is what appears to be some combination of endobronchial disease and some extrinsic compression coming from the right side. This is a patient that might potentially end up requiring tumor debulking, plus or minus after the tumor debulking. You might realize that the patient perhaps could benefit from a stent as well. But we're going to back up and look at the overall picture to decide if anything. Okay, well, with the indications out of the way, for the most part, although I'm going to come back to differential indications for various technologies, let's look at the kinds of instruments and technologies that are at our disposal when it comes to tumor debulking. So let's start from left to right. Here's just a like a menu of all the different options that we usually use. There's mechanical debulking, right? So if you see an area that has tumor or whatever have you, you might use your flexible forceps, your rigid forceps. You're performing a rigid bronchoscopy, perhaps even just the beveled edge of your rigid barrel, your bronchoscope, brachioscope, to pour out a little bit of the tumor or a lot of it. That's one approach. There's cryotherapy, which we will talk about in greater detail today. And by the way, cryotherapy, when I say cryotherapy here, I'm thinking really about contact cryotherapy that involves a cryoprobe that you touch the lesion with. And there's electrocautery, there's argon plasma coagulation or APC, and then there's laser. All three of these are what we call hot therapy. They all involve raising the temperature of the target lesion and causing essentially some of it to evaporate. Then there's brachytherapy, which is high-dose local radiation therapy, not used as commonly. There's photodynamic therapy, which is not a hot therapy because you're really just using almost, within the usual spectrum of light, visible light, and that leads to a delayed effect. And then there's spray cryotherapy, which has become a little bit more popular over the recent past. So let's look at some of these in differential ways. There's different ways to classify or think through your options. And here's how I think through these options. So one way to think through these is which of these requires me to touch the lesion? The first three: mechanical debulking, contact cryotherapy, or electrocautery. You gotta be touching your instrument to the lesion in order to cause effect. Another way to look at it is which of these will give me an immediate effect and which won't. That's important, particularly if you're dealing with a very central area obstruction. If you have a major obstruction in the trachea, the patient's in respiratory failure, you don't really have the kind of time to wait and wait for that, the whatever you did to cause its effect. I apologize for 1 second. We doctors never really get a break. It is a Saturday morning right here in Boston, USA, but I'm getting a page from the hospital, although I'm not on call. I'm gonna shut off my camera for just a little bit. Thank you for waiting and understanding. So immediate effect is important, right? When we're really dealing with a very central and a very marked. So brachytherapy and photodynamic therapy really lead to a delayed effect. And then cryotherapy has both an immediate effect and a delayed effect. So there's a portion of each of those. Another way to look at them is the depth of effect. Now, this can be quite variable across different tools, but one thing that I do want to point out here is APC, or argon plasma coagulation. If you see my cursor here as well, you will notice that argon plasma coagulation has a very minimal depth of effect, and that is key when you're really trying to limit your effect to a very, very superficial area. We don't want to get too far off from where the lesion is. You don't want to get and cause any airway perforation, for instance. And then another just equally important thing to keep in mind is fire risk. And we're going to talk about that a little bit more shortly as well. Some of these, the same therapies that I labeled as the hot therapies, make sense, also come with a risk of airway fire. And in those cases, you're going to have to deal with that constant risk, and you'll be in constant communication with your anesthesiologist to make sure that you're setting the stage for no airway fire. In other words, no combustible or as little amount of combustible gases in the airway as possible. Now I'm going to try to see if I can clear my drawings. There we go. We don't need those drawings any further. But before we move away from the technologies, I want to talk in greater detail about the most frequently used technology. And those are going to be today cryotherapy and argon plasma coagulation. Let's dive really deep into each of them one by one. First, contact cryotherapy. So what is cryotherapy? It's cryo ablation or cold therapy, as the name implies. What are we trying to do? We're using extremely low temperatures to destroy target tissue at the cellular level by causing destruction of organelles inside of the airway, causing apoptosis. How do we achieve this? We take advantage of the Joule-Thomson effect. So, a gas rapidly cools down as it expands if you had pressurized it in the first place. So all natural gases except hydrogen and helium have this property. Most of the times we use carbon dioxide or nitrous oxide or liquid nitrogen. Those are the gases that are typically used as cryogens for medical cryotherapy, but really you can use a lot of them. And what is cryotherapy good at accomplishing? It's really a two-in-one tool. So one way to use cryotherapy is to perform cryoadhesion. You have a big piece of clot or a big piece of tumor that you have just debulked using, let's say, your mechanical forceps, but it's still sitting in the airway. All you need to do is to pick it up and take it out of the airway. Cryotherapy is great at it. You just freeze the lesion or whatever you want to get out of there. And then while you're still stuck to the cryoprobe, you take out the cryoprobe and throw it away. Freeze and pull. The other way cryotherapy works is cryoablation. That's the delay. So what are you doing over there? You're really cooling down tissue to a great degree. Usually I do that for 30 seconds at a time, and then you let it rapidly thaw. And then you repeat. And when you do that a few times, it'll really induce apoptosis. This will be a delayed effect, best seen usually around the 48-hour mark, but that's another way to cause tumor ablation. So here are two pictures showing one of each thing. Cryoadhesion of retained secretions and a little bit of residual tumor on the left. And on the right, you're looking at the cryoprobe causing cryoablation. This will be just rapid cooling followed by slow thawing. Now, what is cryotherapy not good? Cryotherapy is actually, and this might be a little counterintuitive, and I'll explain why, but cryotherapy isn't great at achieving hemostasis. Now, why do I call it counterintuitive? It's because I know we do often think of using cold or ice saline when we're trying to manage bleeding, the idea being that it could cause some localized vasoconstriction. And sure enough, cryotherapy will be able to achieve that. But in general, if there's an actively bleeding lesion, you'll find that cryotherapy isn't great at fixing it in the same fashion or to the same degree as some of our other tools in our toolbox. So cryotherapy is not your go-to tool for achieving hemostasis. Another thing cryotherapy isn't good at is trying to freeze tissues that have low water content. Think a foreign body in the airway. A foreign body in the airway, if somebody aspirated a metal coin, you will not have great luck trying to stick that to your cryoprobe. What you need is enough water content in your target tissue that can easily crystallize, become ice, and that is what allows that lesion or that tissue to get stuck to your cryoprobe. So your cryoadhesion won't go great if there is low water content. Cryotherapy, not your go-to tool for foreign bodies. Okay, let's talk a little more about APC, or argon plasma coagulation. So useful, but with a lot of risks. So argon plasma coagulation is a combination of an electric current and an ionized argon gas. The plasma, the word plasma really refers to the ionized form of that ionized. So what are we trying to do here? As opposed to using a simple electrosurgical probe or cautery probe, as it's colloquially called, you're using an argon gas that enables you to conduct electricity from the site of initiation where the spark comes to the tissue itself. So now this has become a non-contact mode. Otherwise, it's pretty much an equivalent of electrocautery. This is a non-contact form of tissue ablation. Why is it useful? Well, it's useful because one, you don't have to touch the tissue, and we'll see how that can be useful. And two, you can now take turns. Your plasma can actually turn corners and sort of follow the path of an airway. So if you have a lesion that's a little bit harder to get access to, the plasma will still be able to get there and the current will flow. So you might be able to achieve better tissue ablation using APC. It's also good at achieving hemostasis. And so because, it sort of spreads out the way you can imagine a gas to spread out, you can easily cover a bigger area, a larger surface area than you could with electrocautery or laser. So what is APC really good at accomplishing? The name gives it away, right? APC, argon plasma coagulation. It's great for achieving coagulation. It's an excellent tool for achieving hemostasis, a rapid carpet bombing of the area that might be bleeding. And it's also good for tumor debulking as well, particularly closer. The closer you are to the surface, the higher the temperatures, the tissue temperatures that it'll achieve, and that could eventually lead to vaporization, just like you would imagine with something like laser. The one advantage of APC here also is, and we talked about it earlier when you were looking at that table, it has a very, very superficial depth. So that allows you to be a little bit safer and decreases the chances of airway perforation, limiting the effect to the very superficial aspect of the airway wall. And then there are a few factors that I want you to keep in mind that can help you potentiate or modulate the degree of tissue effect that you want to cause. So I should back up and say that the APC settings, when you're setting up your APC on your console, it's not one uniform setting. There's a few options to choose from. The most typical classic setting is called a forced APC or APC forced. That is the one that is closest to the original APC technology that came out in the 1990s, right? And what you're getting there is a constant flow of energy. Compare that with APC pulse. As the name suggests, those are pulses. So you're getting there's an APC pulse setting number 1 where you're getting 1 pulse of APC per second, or APC pulse number 2, where you're getting up to 16 pulses per second. And the advantage there is that you have these tiny breaks that allows you to make sure that your tissue does not get overheated. These are great for coagulation, right? Because you really don't need that constant flow of energy. And then the third one is called the precise APC precise. Now, the APC precise setting is meant to sort of take one of the variables out of your hand. So even if you are having difficulty keeping your probe at a constant distance from the target tissue, the APC precise will adjust, auto-regulate the amount of power, the amount of energy that it is delivering based on how far you are from the target tissue, as long as you are within 5 millimeters of tissue. So with that said, APC force would be the typical setting that you will be using, or perhaps you may want to use APC pulse. But what are the ways that you can sort of potentiate your effect? Supposing you really did not want to achieve coagulation, but wanted to use APC as a true tissue debulking tool. You want to maximize the energy, but in a safe manner. There are different things you can do, and you just need to know what causes, what amount of effect. So duration of activation, if you look at these bars here, duration of activation has the highest influence. It isn't something I readily recommend though, and we'll talk about it momentarily again too, because that might potentially be worrisome for risk of airway fire or just causing extra damage or airway perforation. So usually I try to avoid activating my APC for any longer than a few seconds, but know that if you are going to do it, when you are doing it, when you need to do it, you can simply increase the duration of your activation from, let's say, 2 seconds to 4 seconds at a time, and that will increase the tissue effect. Take it from coagulation toward vaporization of the tissue most immediately in front of you. Another thing you can do is to just up the power setting. So let's say go from 30 watts to 40 watts or 50 watts, and that will also increase the tissue effect. And then the third thing is the probe distance. So, the closer you are to the tissue, the greater the effect, but to a much less degree. And you really want to steer clear of touching the tissue. Plus, we talked about the APC precise setting where the third factor will not play any role at all. Safety measures. We've talked about it a little bit already. As I promised, there will be some overlap, but let's really dive deep into safety. So first, let's remind ourselves of what are the life-threatening risks that come with both cryotherapy and APC. And a lot of those are similar to across the different types of tools that you might be using, but I'm really using these two most commonly used technologies as examples. So first, cryotherapy. Well, if you're doing cryoadhesion, stick and pull, you could cause major bleeding. If it's a friable tumor that you're trying to debulk through cryoadhesion, it's quite possible you may end up with massive bleeding. That's one life-threatening risk. Another one, which is very, very uncommon, because cryotherapy is generally, fairly sort of superficial as depth effect, but it's nonetheless very much possible, especially if you're going to be doing this distally, as you might do for diagnostic cryobiopsy. We're not really talking about that in this webinar today, but the same principle applies. There is certainly a risk of airway perforation, pneumothorax, pneumomediastinum. When it comes to cryoablation, that contact cryotherapy, where we're doing the slow thawing following a rapid freezing, there's usually no immediate life-threatening risk with that. However, if you were doing that in the trachea, 2 days later, if there's a lot of sloughing off of necrotic tissue, it could potentially lead to an airway obstruction that has just gotten worse and could lead to respiratory distress or respiratory failure. Could become life-threatening as well, potentially. So what are the safety measures to undertake? Well, one of the things to keep in mind is to really select an appropriate cryoprobe, right? So if you're really doing something a little more distally in a smaller airway, you don't want to use the largest cryoprobe first, because what you don't want to do is to accidentally be touching the normal healthy areas within the airway mucosa. You want to make sure that your effect is really limited to the target area, the lesion or whatever area that you want to freeze. And another thing to keep in mind is, and I try to do this every single time. This is very important. Before you start using your cryoprobe, just take a little bit of water or saline, and this is in vitro, not in vivo, and then step on the pedal, put the cryoprobe in the water, and see how many seconds it takes you to achieve the size of that popsicle that you want to achieve. So what you want to make sure is that you're not freezing the target tissue any longer than you need to. And this is something that is going to vary from case to case to a little bit, because it depends in part on what's the pressure of the cryogen in your cryo tank at the moment, and what's the body temperature for the patient. So that's something you cannot control in vitro, but nonetheless, doing this exercise every time will give you a good sense of how long do I need to press the pedal, one, and two, just this exercise will remind you of the need to be careful and not do it for a longer period of time, particularly when you're going to be doing cryoadhesion, because you don't want to freeze a bit of normal airway wall and then start yanking it up. And always, always, always have a robust plan in place ahead of time for bleeding control. If you're going to be using cryotherapy, bleeding is always a possibility. And as we discussed earlier, cryotherapy isn't the best tool for bleeding management, so you want to make sure that you have a robust plan in place for bleeding control. Okay, what are the life-threatening risks that APC entails? There's a few to be really mindful of. One of them is, mucosal or submucosal airway injury. Again, if your depth of penetration became larger than was appropriate, this is certainly a possibility. Airway perforation is a possibility, unlikely with APC. And that's one of the big reasons why APC is such a favored and a popular tool, because the depth of penetration is usually fairly constant, fairly uniform, and very superficial. But nonetheless, never say never. Airway fire. Airway fire is a very real risk with APC. And this, of course, as you can imagine, can be life-threatening, absolutely is life-threatening. Respiratory failure, asphyxiation, death, or even if the patient were to survive a major burn, smoke inhalation injury, all of these are real possibilities. Airway fire should really be a never event. If there's enough flammable gas in the airway while you're firing APC, this could very much happen. If the APC probe, the electrode, touched the tissue or touched the tip of your bronchoscope, if you hadn't pushed it out enough, either the tissue or your bronchoscope could catch fire. Well, so airway fire is very much a life-threatening risk. And this is something that is true for both electrocautery and laser, in addition to APC, all three of the so-called therapies. And then another one that comes with APC, because you're using a gas here, argon, is argon gas embolism. A gas embolism, it could get into the venous circulation and cause a PE, a pulmonary embolism, or it could get into the arterial circulation and cause acute coronary syndrome or stroke. And in either cases, of course, it would cause death. So this is also, a never event that should never happen, is a very real risk with APC. And we have some understanding of why it happens. It appears to be related, based on prior research studies, to high gas flow rates, one. So when you're setting your APC, and I'll show you a picture of a typical setting, you want to really make sure you keep those gas flow rates low. Secondly, direct mucosal contact with the probe could also increase the chances that you're depositing a lot of that gas, not in the airway lumen, but in the submucosal. And from there on, it might be much easier for that gas to get inside the intravascular and cause this potentially fatal complication. So airway fire and gas embolism are the two real big problems, life-threatening events you should really target to see them never in your career that can happen with APC. So what are the safety measures to undertake? We talked about safety measures for cryotherapy, now safety measures to undertake during APC. You gotta use low flow settings. I typically use a very low gas flow setting of 0.5 liters per minute. I would say consider doing something similar. Use short bursts of APC at a time. I think in general, unless you really must cause tissue vaporization and very quickly, let's say you're in the trachea and there's no time to lose before the patient really becomes more hypoxic, in which case you should potentially consider some other tool anyway, maybe laser, maybe mechanical debulking using the rigid core, or perhaps cryotherapy with cryoadhesion. But nonetheless, unless you're doing that, you should really try to limit your APC to short bursts at a time. Keep your APC probe away from the tip of the scope when you're firing, because your bronchoscope can catch fire as well. And similarly, keep it away from the tissue as well. We talked about how important that is. You don't want to deposit that gas in the submucosal space. You also don't want the tissue to catch fire. And if you're using conventional ventilation, let's say you're performing the case with flexible bronchoscopy alone, before every time you start using APC, you have to speak with your anesthesiologist about making sure that the amount of oxygen concentration, partial pressure of oxygen in the airway is as low as it possibly can be. So they must make sure that your FiO2, and really ideally also be measuring FeO2, which has really become standard of care now, are both below 40%. So what's FeO2? That's fraction of expired oxygen, right? So what's coming from the alveoli when the patient is passively exhaling? That will often be higher than what you're delivering, the FiO2, or fraction of inspired oxygen. But really, both of those need to be less than 40%. If you're performing jet ventilation, as you might be doing during rigid bronchoscopy, that is how I have my anesthesiologist ventilate the patient. When I'm doing rigid bronchoscopies, you must ask the anesthesiologist to absolutely and completely hold the jet during your burst. So when you're firing, there should be absolute cessation of jet ventilation. And last year, the American Association for Bronchology and Interventional Pulmonology also came out with a statement that you can look up online, basically talking about the same things that I talked about whenever using any of those hot therapies. So electrocautery, argon plasma coagulation, or laser, you gotta do all the things that we just talked about. Here's an example of the typical APC settings that one might use. So you can see my flow rate here. And you're really looking at the right of the screen, right? Because it's the blue mode. APC is a coagulation mode, not a cautery mode. So the yellow pedal is completely useless for you. When you're using APC, you're really pressing on the blue pedal, and you're really changing settings on the blue side of the screen. So in this case, I'm using the classic APC mode. My flow rate is really low. It's 0.5 liters per minute. I've gone as low as 0.4 liters per minute. And my maximum watts are 30. That's pretty much a starter setting. Finally, managing complications. So supposing something bad has happened, what do you do next? Airway bleeding. The same principles apply for airway bleeding related to cryotherapy or any other form of tumor debulking, mechanical debulking, etc., as would be the case for any other kind of airway bleeding that you are trying to manage. A lot of the times I found that just using gravity to your advantage can be all that you needed to do, along with the tincture of time before the bleeding would subside, and you would make sure that the blood does not spill over into the other lung, the good lung, the unaffected lung. This, of course, does not apply if you're bleeding. The site of bleeding is in the trachea, but it does apply if it's more distal than that. So you want to get the bleeding site dependent. If the patient's bleeding in the left main stem bronchial area, you want to ask the anesthesiologist and your team to help you move and turn the patient with the left side down so that with gravity, all the blood stays in that area and does not go over to the other side. Secondly, you want to isolate the bleeding site whenever possible. Again, the idea is the same. You just want to make sure that the bleeding does not go over to the other side. How do you do that? Well, with your flexible bronchoscope, you can wedge your scope and just make sure that the blood remains there. You can use a bronchial blocker. There are several commercially available blockers available. Intubation of the contralateral main stem bronchus is an alternative to using the bronchial blocker. Not my favorite personally because it's it's hard to ensure that no amount of blood is going to spill over to that contralateral side with that technique, because you typically your endotracheal tube's balloon will still be proximal enough to be sitting in the trachea. So I prefer using the bronchial blocker, but whatever works for you, and ideally you have tried this before, and so you're ready to go if you are facing such a scenario. And very importantly, during all this time, I always make sure to perform therapeutic aspiration of any spilled over contents, right? You want to make sure that all the bleeding is staying in one area and you're not letting it all go into the other side. So nobody ever expired because of hemodynamic instability or exsanguination in the airway. The biggest risk is asphyxiation, and that's what you want to prevent by making sure that nothing is going over to the other side. Now, as far as hemostasis is concerned, sometimes you really have to take the bull by the horns, right? Ice saline is a commonly used approach. I will tell you personally, I don't often use ice saline because you got to really make sure that you have good access to the site of bleeding, and you can clear up the site quickly before you instill ice saline, and that's the only scenario in which it'll really get to cool those submucosal vessels and cause some transient vasoconstriction. Otherwise, it's just going to add to the pool of red secretions, red colored secretions that you have to then clean up and potentially also worsen ventilation. A pharmacologic hemostatic agent such as tranexamic acid is very much a possibility. Some people really like to use topical epinephrine. There's some data that can increase the risk of arrhythmias, no surprise. I really stay away from epinephrine in all instances, really, but tranexamic acid is something you could certainly try. And then, of course, one of the tools we've talked about a lot today, APC, is a great tool for achieving hemostasis if the site of bleeding is well within your reach. So a lot of the times, if I'm performing therapeutic bronchoscopy and I know exactly where the bleeding is coming from, I might reverse this order and actually use APC first and foremost, and a lot of the times it's going to fix the issue and nothing else. How about managing airway fire? So I have to use the disclosure that thankfully, knock on wood, I have not encountered this in my career to date, so I don't have first-hand experience, but having spoken with colleagues about this, having, of course, thought and spoken about this in detail with trainees, with colleagues many times, because you want to make sure that you're prepared for that eventuality. And having looked at some published data in terms of people's successful experiences managing such a complication, here's what I have to offer. One, you want to make sure there's no further ignition. So APC, cautery, laser, anything that is a hot therapy, an absolute no-no. If you see it, you're done. You're not going back to any of those in the moment. You must disconnect any and all oxygen supply, hold ventilation. You must make sure that you're not adding fuel to the fire. Suction out any remaining flammable gas that's in the airway. So use the suction on your flexible bronchoscope and suction out as much of the flammable gas as you can. But of course, make sure that your scope remains as far and away from the site as possible, because you don't want it to catch. If the endotracheal tube caught it, you should consider, and this is just based on what I have come across in published literature, consider an ultra rapid extubation, removing that endotracheal tube. I would be very careful about that because you don't want it to sort of latch on to the fire to latch on to other areas as you're removing the PT tube. And another con to consider would be if the patient is a difficult airway, would you then be having issues reintubating? But something to consider for sure. And then another, which could be a really good tool there, is a saline wash, right? Think fire extinguisher. So something to really disconnect the fuel from the fire and let it get extinguished. Last but not least, managing gas embolism, the other big complication of APC. Again, this is something that you must talk about and discuss and educate your trainees on and yourself on repeatedly, even if hopefully all of us or most of us will never get to see this in our careers. So hemodynamic support is very important. Volume expansion can do wonders, right? If you can increase vascular pressures, that will also decrease the gradient for atmospheric or airway-based gas to travel into the blood vessel. If the patient, requires it, you might end up needing CPR as well in this case, right? If it's a massive PE or acute coronary syndrome, there is certainly a possibility of cardiac arrest. You must control the airway with endotracheal intubation and deliver oxygen. Oxygen. It's sort of the absolute polar opposite of what you need to do for an airway fire, right? Stop the oxygen there, give the oxygen here. Why? You're trying to wash out that gas. 100% oxygen at a minimum, but really if there are severe complications such as acute coronary syndrome or cerebrovascular accident, you're really doing hyperbaric oxygen to push the argon gas out of the way as much as you can. And then the rest really supported management. Now, if this was a venous gas embolism that traveled into the right side of the heart, you can turn the patient to the left lateral decute position to move those gas bubbles into the right atrium before they eventually hopefully just get dissipated before that gas could go farther down the tree. Okay, well, we have, let's see what time we have. I want to keep a little bit of time for questions too, but I came with a couple of quick questions of my own as well. Let's quickly test our understanding. Let's see what we have learned today. First, which modality would you use to control rapid airway bleeding from malignant airway disease in this case? So you're looking at the airway, you're looking at sort of submucosal disease that is relatively sort of diffuse, and you can see a lot of bright red heme right there. It is causing, there's bleeding going on from the malignant disease. What would you use here? I absolutely would use APC here. You need something that is superficial. You need something that can quickly spread across a wide swath of area, and that is pretty safe and will achieve results quickly. APC would be my go-to. Okay, next question. What maximum FiO2 would you request the anesthesiologist to use when you're performing cryotherapy? So that is a trick question. There is no FiO2 that is contraindicated when you're performing cryotherapy. Cryotherapy is a cold therapy, not a hot therapy. There is no risk of airway fire, so you don't have to communicate with the anesthesiologist about a certain FiO2 setting in that case. And which modality would you use to bronchoscopically remove an aspirated tooth? This is a tooth that I removed from the airway of an 8-year-old who had aspirated it. So what you won't use here is cryotherapy because the tooth has essentially no water content, and therefore it won't be very useful in terms of getting this stuck to the probe and yanking it out. What you really need is a mechanical tooth. I often use stone retrieval baskets that the urologist uses, and many other similar tools. So that brings us to the end of the talk today. We talked about various tools. We began by talking about the indications, but mostly we talked about cryo and APC. We know that cryo can be very effective at achieving both rapid tumor debulking, but also slow poisoning through apoptosis, but it's not the best at achieving hemostasis. That's where you use APC. APC is also useful for tumor debulking if you use it wisely and carefully, but it carries some very real risks, particularly airway fire and gas embolism. So you have to be very careful and keep in mind both the safety measures to take to prevent it and also what to do in case any of that does happen. Ultimately, what we started with was thinking really carefully about choosing wisely what tool and if any at all to use in cases of airway obstruction. Because the worst thing we can do to a patient is to perform an intervention. They all carry a risk. That wasn't indicated. The best surgeon knows when not to. Thanks for your time. Happy to take questions.
Thank you very much, Dr. Shafiq, for this excellent, practical, and very didactic talk. And if there are some questions from the audience, please raise your hand or put on question.
Thank you, Dr. Simon. Go ahead.
I'd like to ask you, do you use cryo for benign post-intubation tracheal stenosis? Do you use cryo?
Yes, I do. In fact, I just used one yesterday in the OR as well for an identical case. I have found cryo to be very useful for those situations. And in fact, also for post-tracheostomy granulation tissue bites. That is something that we, of course, saw a lot of in the COVID years because so many people were coming out with tracheostomy in place, prolonged trachs even. But really, generally, for all benign subglottic or upper tracheal stenoses, I found that cryotherapy appears to, because it's not fibrogenic, doesn't really lead to any scarring. It doesn't appear to, over time, increase the length of the diseased tissue, which will make things harder for a surgeon down the line. Things I worry about with laser or electrosurgical knife and so on. I tend to use cryo quite a bit. The one caveat, though, is that if you have very severe obstruction in the trachea, and most of the lumen's already gone, and then you use cryotherapy alone, there's a real danger of the patient coming right back with life-threatening respiratory obstruction when the tissue starts slopping off in 48 hours.
Thank you. There is a question from audience. Has come from Camila Gregiani. What is your thoughts on prophylactic stenting for asymptomatic malignant central airway lesion?
Yeah, thank you for the kind comments and thank you for asking that question. I don't use stenting ever for asymptomatic patients and prophylactically. In fact, I tend to be very conservative with stents. So, the best stent is a stent never placed. I am always looking to prevent, my patient from getting a stent, which is really a new disease. I feel like whenever I can, in cases of mixed obstruction, I would rather just perform tumor debulking, really look carefully at the overall picture. Does this patient have a radiosensitive tumor that is about to undergo radiation, for example, or a chemosensitive tumor, or is the patient chemo naive and about to hopefully start responding to chemo? In all those cases, if I've already improved their case where now, with the tumor debulking or maybe even just balloon dilation, they will be better off than they were when they showed up to me, I will consider giving them some breathing space, bringing them back in a few weeks, looking again to see if they really need a stent. But whenever possible, I really try to not put in a stent. Stents cause a lot of infections. You can end up with a lot of mucostasis and paradoxically airway obstruction from it as well. And not to mention migration and so on and so forth, fracture and whatnot. We've all seen all kinds of complications. It really is a new disease. I would love to spare my patients that whenever we can.
Another question from the audience. For tumor debulking mechanically, Is there a role for cryotherapy upfront to help decrease bleeding during debarking?
That's a great question. I will say this is a way that this is an approach you could use with APC actually, with even greater effect. So just use it, very gently earlier. I see what you're saying. What you're trying to say is, before we even do anything, can we just uh, sort of decrease the chances of bleeding before we get really dirty into the tumor, right? Well, what you really want to do is, I love where you're going with that, but I would say, why not use APC for that? Because APC causes coagulation, get the vessels, neutralize the vessels through the APC, and then bring out your forceps or your rigids. Now, if you are not using APC for any reason, and there are many reasons to not, you're supposing you don't have to, or you don't have it, or whatever have you, then yes, then I think it's not unreasonable to use that the rapid freezing to 30 seconds followed by a slow thawing process so that you get some degree of vasoconstriction locally, and then go ahead and perform mechanical debulking. I think I have done that very, very occasionally in a situation where I, for whatever reason, did not want to use APC at all. But really, I will say use it. I love where you're going with that. Use APC for that exactly. Good question.
Thank you. Another question from the audience. Does increasing our APC duration also increases the depth and lead to perforation of the airway?
That's a great question. So, the package insert says that the APC's depth of penetration is very constant, very consistent. My feeling is it's probably true. I think what probably happens when you increase APC duration or any of those things that I showed in that schematic with the bars, what probably happens is that you change out what is the depth of, let's say, vaporization, or what is the depth of tissue that is getting heated up to the maximum degree without necessarily increasing the overall depth of effect of APC. And because you're not really increasing the overall depth of effect of APC, and that depth of overall effect, even minimal, is so superficial, typically, no more than 3 to 5 millimeters, my feeling is that airway perforation is exceedingly unlikely with APC. However, I would worry about that too. And in general, with all interventions, and you can probably tell from my answer about to the stenting question, I'm a less is more guy, and I highly recommend that we exercise caution, respect for the human body, and really only do as much as is necessary to achieve the aims that we have set.
I would like to ask you, do you use Fogarty balloon in place prophylactic before cryobiopsy, or you place only blocker if the hemorrhage appear?
So I have to say that my practice has evolved of late. So my typical way to do a cryobiopsy has been to, and I know that every institution and so many providers do it very differently, right? With biopsies, there have been so many expert statements and guidelines now too, but there's a need for standardization still. My typical way has been to perform a rigid bronchoscopy, and just like you said, Dr. Simon, using a Fogarty balloon, that has been my approach typically too. So, my assistant is going to inflate the balloon just as soon as I take out my cryoprobe and make sure we tamponade the area and not take any chances. However, with the advent of the robot, I often find that just the robot itself does a great job at really occluding the airway, because you're so far out, you're so distal now that the diameter of the lumen of the airway is matched by the size of the diameter of the thickness of my robot. And so that alone, just keeping it there in between passes, does a great job at achieving tamponade, and I don't have to sort of do anything else. So if I'm doing a really, really superficial cryobiopsy, I'm not using the Fogarty if I'm using the
Thank you. Another question from the audience. Any nuances using APC in a patient on ECMO in terms of gas embolism specifically?
That's a really good question and a good thought. I don't know if it really changes anything. If anything, I do worry about one thing, the same principle of staying clear of the tissue. Why? Because potentially, it could go either way. It could be a less risk in my mind, but potentially, depending on what your settings are for ECMO, the question is going to be, what are the current vascular pressures? If the intravascular pressure is actually really high and healthy, it might actually be better than that of a patient who is undergoing mechanical ventilation, typical anesthesia, and is a little bit hypotensive when you're doing it. When the patient's hypotensive, you worry about that differential gradient, allowing more gas to enter from the airway into the vascular space. However, if your ECMO setting is such that your pressures are actually, fairly healthy and robust, then maybe the gradient has actually improved. And now there's a lesser chance of the gas, entering from the airway into the vascular space. However, we all know with ECMO, that's not always the case. So I wouldn't worry about it, but I would say the same good principle applies. Make sure we are sufficiently away from the site that you're treating. Never be touching the tissue that you're treating, and keep the flow rates as low as it. Great.
Thank you. Other question, when and in what situations do you use cryo spray?
Yeah, I will say personally, I haven't used cryo spray yet. I have certainly sort of tried it in a simulation setting or in a cadaveric setting a few times. I think it's great, very promising. I think it's really useful, particularly if you're got a big swath of area that needs treatment. I do worry a lot about the risk of pneumothorax, which is very real, the barotrauma. It is something that your whole institution needs to be comfortable with, your anesthesiologists need to be comfortable with. That is simply not the path that I have taken yet at my institution. We are blessed with having multiple tools and for multiple types of diseases, and of course your attention, your efforts are usually divided across all of them. At the moment, I don't have a lot to personally share with you, but
another question from the audience, which you will prefer, rigid Fogarty cryo versus use of laryngeal mask, flexible and Fogarty and cryobiopsy in terms of saving and safety?
Yeah,
do you use laryngeal mask or you use usually rigid bronchoscopy for cryo?
I would between those two, I would absolutely use the rigid whenever possible. I think it would be both time saving and safer. So I think from both standpoints, it would be good. I guess there's not much time to be saved, but if you're, it doesn't take you much of any time to get to the rigid. In fact, you take away one step of the anesthesiologist placing the airway for you and then handing the case over to you. Rather, as soon as the patient is induced, you go right ahead, you get your rigid in, and you're good to go. So I think you're actually saving time that way. And secondly, safety-wise, you want to make sure that the cryoprobe with the lesion that or the tissue that you've gotten, and we do veer a little bit away from the therapeutic bronchoscopy, but I'm loving the questions. Thank you for asking all these questions. So I know that is diagnostic, not therapeutic bronchoscopy, but nonetheless, you want to make sure that the tissue that you just acquired is also safe and doesn't get hung up on the cords, doesn't injure the cords. The cryoprobe that you might still be potentially pressing the pedal on is not touching the cords. Next thing you know, heaven forbid, you're freezing the cord and trying to yank it out, right? So I would absolutely use the rigid between those two, and I would not expose the vocal cords.
Another question from.
And I apologize, Dr. Simon. Not to mention, the very real risk of major bleeding with cryobiopsy, in which case you would be scrambling then to achieve hemostasis, right? With an LMA, really hard to get a balloon blocker in place, really hard to secure your airway. You would almost certainly be needing to exchange out your.
Yes, in my opinion also, it's better rigid bronchoscopy when you perform cryo. Another question for cryobiopsies for interstitial lung disease, do you use 1.1 or always 1.9 cryoprobe?
Yeah, with the new single-use disposable cryoprobes that have come out now, I used to use the 1.9. At the moment with these, I'm really mostly using the 1.1, and I found that it's really useful. Not so much in terms of there's of course the theoretical advantage also that it's it's smaller, so hopefully its depth of effect is smaller, and you have a lesser chance of freezing a major vessel and then rupturing that, which is great, or a major airway. But on top of that, I find that the 1.1 also allows me to go much farther out, and it doesn't get sort of hung up on an airway carina as much as a 1.7 or formerly the 1.9 made. So generally, yes, I do like the 1.1 cryoprobe if it's getting me good sense.
Thank you very much. Another question. If you have a tumor that obstructed the bronchus, and you can't go with snare, electrocautery snare, and take off the tumor, what do you perform? Electrocautery, marginal electrocautery, or with rigid biopsy forceps? What do you make in this situation? Because a lot of time I have this problem. The tumor has a large implantation base, and it's impossible to extract with snare.
Yeah, and you're right. That is so true. A lot of the times that base is just so wide, and there's just no way that what I have learned is not one approach, but here's a couple of things that I try. One of the things that I try is if it seems that the tumor isn't particularly vascular. In those scenarios, I often end up trying cryoadhesion with great results, because you can actually, that might be the quickest way to do it. Just start cryoadhesions and just yanking out as much as you can at a time. If it is in the proximal or mid trachea and it's not particularly vascular, or it's moderately vascular, I might actually do a rigid coring as well with the bevel. And then keep my APC at the ready, make sure the patient's grounded, make sure my probe's out, make sure my pedals are within reach, and my APC settings are ready to go. Because after mechanical debulking, often you're gonna need cryo APC for hemostasis, right? Another thing that I do sometimes in those cases is actually I still use the cautery snare, and I do it repeatedly. And sometimes, after like the 5th try, I'm able to actually get the whole stalk out. Doesn't always happen, but I've certainly tried that as well. And then I can use the cryo, right, to yank holes.
Yes, thank you very much. Indeed, there is no general recipe for therapeutic bronchoscopy, and choosing the endoscopic technique that will be used depends on the patient characteristics, expertise of the team, and on the available techniques. And I think the best therapeutic approach is a combination of the treatment modalities and should be personalized for each patient. Thank you very much for this excellent talk and for the answers, a lot of questions. I think it's a very good job. And I would like to underline the webinar is made be possible in part by sponsorship from Ambu company. And thank you very much for the audience, for this very interesting comment and answers and and questions. And I wish success in your activity. And thank you very much again.
Thank you from my side as well, Dr. Simon and everybody else. Thank you, WABIP.
Thank you, WABIP, for this idea to be to have this very nice, interesting subject. Thank you very much.
Thank you, both of you, for being here.
Take care.
Okay, thank you.